another episode of Well-Adjusted Mama. I'm your host, Dr. Laura Brayton, and today's guest is Dr. Eden Fromberg, who will be speaking on BioIntelligent Childbirth. Dr. Eden Fromberg is an integrative, holistic obstetrician, gynecologist, and osteopathic clinical professor whose innovative and engaging approach to reframing the medical dialogue and implementing effective health and wellness strategies with her patients and clients is unique and biointelligent. Merging ancient wisdom with cutting-edge research and innovation, Dr. Fromberg's women's health practice at SoHo OB in New York City is a sanctuary for truly holistic women's health care, and Dr. Fromberg is also the founding director of Lila Yoga, Dharma Wellness, where she teaches and curates BioIntelligent Movement, Integrative Wellness and Yoga for women, prenatal and fertility programs and trainings. Dr. Fromberg's extensive and diverse background, years of clinical experience, dedication to caring well for her patients, and active interest in current research and innovation give her the opportunity to sort out complex issues and offer a range and depth of options to meet her patients' needs. In addition to her expertise in integrative fertility, pregnancy, and birth, Dr. Fromberg applies a functional, structural, biointelligent, integrative approach to addressing all areas of gynecology and beyond, incorporating gynecological visceral manipulation, anthroposophic medicine, and prevention in addition to symptoms. In addition to her busy medical practice and wellness studio, Dr. Fromberg teaches and consults locally and internationally, appearing in the film The Business of Being Born and in the Pregnancy Health Guru series on fetal development. She's worked intimately with midwife Robin Lim at the Bumi Sehat Gentle Childbirth Foundation in Bali, Indonesia. Her work has been featured in Huffington Post, Upwave, Time, Yoga Journal, Bus, Natural Health, Parents, Spirituality and Health, and Midwifery Today. For more information, visit her website at dredenfromberg.com. Welcome, Eden.
Hi, thank you.
I'm so excited to have you on the show today, and I'm really excited to hear your thoughts about birth and with your expertise. So this is going to be great.
Thank you. I'm really looking forward to speaking with you about it.
Yeah. So please, let's start off with telling us about your background and how you really got, as a medical doctor, have gotten into integrative and holistic women's health.
Well, I would say it kind of went the other way around. I was already interested in integrative and holistic women's health, and that was one of my motivations for going to medical school. What it was is that when I was 17 years old, I was traveling, and I met some young women who introduced me to the concept of midwifery, which I hadn't been aware of as a 17-year-old, and they were showing me books like The Farm. Ina May Gaskin had written a book called Spiritual Midwifery. Suzanne Arms had a book called Immaculate Deception. Janine Parvati had a book out called Hygeia, and so there were a lot of wise women who had written some great books that people who I met showed me, and I started to read those books, and they had a very profound effect upon me because for some reason I was always fascinated with my body and with birth and all these things, but reading the information in these books, which was written from a perspective of natural childbirth and midwifery and trying to make things better for and empower women, was very compelling to me as somebody who was just entering college, and it really did kind of propel me forward in my career. There were a lot of great feminist women's health books out at the time. There were books out called things like Vaginal Politics, and I read all of them.
That's so cute. I love that.
Thanks.
And so you still decided to become a OBGYN as opposed to a midwife.
Yeah, so I think, part of it might be that I was always very encouraged academically. I have a mother who's an early childhood educator, so she got me off to a great start, and I was kind of over-intellectualized. So when it came to the body, my own personal experiences going to the doctor were kind of weird to me. Like I would go to a doctor with a yeast infection, and he'd take out his speculum and say, let's see which monsters are rearing their ugly heads down there. And I'd say, I can't believe that guy really said that. Who says that to somebody? I better read about this. So that's kind of what spurred me to start reading. But then it was my mother and the academics that kind of spurred me forward. My mother was like, you could go to medical school. You should go for it. And I also was living in Santa Cruz, California at the time. One of the reasons I chose to live there was from reading books about the Santa Cruz midwives. There was a lot of resurgence of midwifery in the early 70s in the Santa Cruz area, so I went out there after college to go and find the midwives, and I found them, people like Raven Lang and Kate Boland, and there were some great people out there, and they really introduced to me the idea that, like, you don't want to be a midwife, you want to be a doctor. And I said, but wait, you're a midwife. Why are you telling me to be a doctor? And they said, no, we need people like you who are really smart and could go to medical school to back us up and help pave the way for, more compassionate natural childbirth, because they were talking about how much they were struggling. Like, if something happened during a delivery, there was nobody who would give them support. There might be a lot of hostility. And so there was this gap in care between what women were doing at home and the midwives who chose to serve them, many of whom had home births themselves as a motivation to help others, and then the doctors and the hospitals who were refusing to collaborate with them and be part of a seamless web of care. And unfortunately, to this day, that's still the case. And so my work is never done.
Yeah, so true. I mean, a holistic OBGYN is somewhat rare to find, so you're a gem.
Thank you. Yeah, it's definitely not been easy, and, the landscape of obstetrics has certainly changed over the years that I've been in practice as well.
Mm-hmm. That's a very good point. How long have you been practicing?
Well, excuse me, I started my residency in 1991, and then I was out in practice by 1995, so, oh dear, that's 20 years ago.
Yeah. And
that's illuminating to even say. Wow.
Right. And, in the past 20 years, what we've seen with the C-section rate in this country, it's, greatly increased during that period. So you saw it when it was a lot lower at the beginning of your practice.
Well, I would say that the way that I was trained has stayed with me the whole time, and part of the problem that I see is that those principles are not being honored. So when I was in my training, the C-section rate was much lower, and I didn't know it from any, other state, but since then it's really climbed a lot. And so I felt like I got really lucky in my training, because even as a medical student, I was being supervised by doctors who already had a lot of experience in whatever way, and so they would let me do anything. So by the time I was in fourth year of medical school, I was doing things like sewing up fourth-degree tears, doing vacuum deliveries, things that medical students usually don't get the opportunity to do. And to be honest, I wasn't sure that I wanted to go all the way into OB. It seemed like a very difficult path and involved gynecological surgery. I didn't know that surgery was really the way I wanted to go, but I think that after my obstetrical experiences and realizing that I really had a sort of an aptitude and natural inclination towards it, it was something I got into. Plus, the way that birth was going at the time, maybe I was a little bit naive that it could be other ways, but in the environments where I was practicing, which were a combination of inner city and rural environments, there weren't a lot of epidurals. There weren't a lot of C-sections. That wasn't what was going on in those environments. And it was almost like if somebody wanted to have a C-section, that was not even an option. You had to have a vaginal birth after cesarean. It was like mandatory VBAC. And maybe it seems nice now to have the choice, but now people almost don't have the choice to have a vaginal delivery, unfortunately. So anyway, the environment that I trained in was very vaginal delivery friendly. Vaginal deliveries were valued. It was considered a beneficial outcome. Cesarean sections were considered somewhat of a failure. If you couldn't accomplish the vaginal delivery, you'd have a C-section. Of course, there were medical and other indications for going ahead to do a C-section, but the value structure was very different than it feels now. And so the valuing of vaginal birth allowed us to make all of the right moves in terms of helping a woman physiologically achieve that goal. And epidurals weren't as popular, especially in the hospitals that I was working in, or if people did get intrathecal anesthesia, which was a different alternative to epidurals that we were doing, it allowed people to walk around more. So I don't know. It just seemed to me that there were ways to achieve physiologic natural childbirth safely in hospital settings in ways that honored women with compassion and empowerment, that were gentle to mothers and babies, and that didn't compromise safety in the least. And I still think that that's the case. that could happen, and that it's really just a bunch of people like digging their heels and not letting that happen, to be perfectly honest.
Wow. And that's what you're still seeing for your own practice, because you're still delivering babies.
Yeah, I'm not delivering so much now. I really only do it for very select people, mostly friends, or, of course, when I'm in Bali, where I also work with Robin Lim at Yayasan Bumi Sahat, I do deliveries there. But at this point, my practice has changed a lot. I'm doing a lot of fertility and prenatal care and counseling so that people really understand what the issues are when they're figuring out what they're going to do in childbirth. But I'm really doing a lot more gynecology, integrative health for women, pelvic pain, and unusual things. And like I said, a lot of fertility and pregnancy care, but not so much the deliveries in New York City right now. But that was one opportunity to tell people more about it. I can really be a resource of information.
Right. That makes a lot of sense, and just educate and empower women that are getting pregnant and preparing for birth. That was one thing I noticed in your...
Sorry, I was just going to say, after a while, I found that a lot of my patients were choosing to give birth with midwives and at home, and, me being their primary obstetrician, especially in a very C-section-friendly environment in which vaginal birth after cesarean was no longer valued. It was becoming much more litigious. It wasn't an environment that was even welcoming to an obstetrician like me, to be perfectly honest.
Right. That makes a lot of sense. The visceral manipulation you do, I thought that was really fascinating. I haven't heard much about that, but helping women with pelvic pain, it sounds like that would be very helpful.
Oh, gynecological visceral manipulation and visceral manipulation generally is unbelievable in terms of how it treats the body, because the body is comprised largely of connective tissue, and we don't really think about that. We think about the organs and the glands and the blood vessels and the nerves, but in between all that, it's not just packing material. It's very sensitive tissue. It's where all the collagen and elastin, all the stretchy fibers that give us support are, and it's a very communicative tissue. So it tells us where we are in time and space, and it tells our cells whether everything's okay or not. It transmits sensations from the environment, mechanotransduction it's called, to the cells, and then the cells decide, are they going to create inflammatory molecules? Are they going to respire and nourish better? So there's a lot going on there. And with female pelvic health, it's a very complex area, but a lot of us, we sit a lot. We don't move in a lot of varied ways, and a lot of pain, tension, and other things can develop in the pelvic bowl and affect the organs, affect pain, affect women's sex lives. So with gynecological visceral manipulation, I'm able to use my hands to get into the connective tissue. It's a technique that's done in a sort of a relaxed way. It doesn't feel as invasive by any means as other medical techniques, because I'm using my hands to gently enter the tissue, and it's really an interaction between me and the tissue. But once the tissue is treated, what happens is the organs suddenly are able to communicate with each other better and communicate within themselves better, and it has profound effects with fertility, with pain, with sexual function, with pretty much all of the functions of those organs.
Wow, that's amazing. That's very cool. And I was even thinking, a lot of emotional trauma can get stored in that area as well and create adhesions in that connective tissue.
Well, of course, emotions are definitely part of it. What people eat, what they think. I mean, there's so much that affects the tissue. Sometimes people are like, what you think? Yes, actually. So this speaks to the principle that I use, biointelligent medicine or biointelligent gynecology. It really means, the biointelligence means that we're trying to support the body and enhance the body and optimize the body, as opposed to impose or disempower the body. And I think that drugs and surgery have their place for sure, but they're not first-line things to implement, especially when a woman's having a baby, and we can certainly talk more about that. But there's a lot of intelligence that's in that tissue, and how that intelligence speaks to us and how we speak to it makes a big difference. And so, there's the conscious and the subconscious levels of that.
Yeah, that's so true. So that would bring me to my next question is, please describe what is biointelligent childbirth.
Mm-hmm. Yeah, so biointelligent childbirth, means respecting the innate intelligence that's in the body and working with it to achieve optimal goals in childbirth. And to me, the optimal goal is happy, healthy mother and baby. And I think that there is this dichotomy that's set up in many people's minds that happy is somehow at odds with healthy. And there's a lot to be said there, because a lot of women and babies nowadays are expressing birth trauma. And, of course, the babies are not able to express it as much verbally, but certainly when a 3-week-old is in a startled body posture, and it's very hard for the infant developmental movement specialist to convince the baby that it can still go back into the fetal curl as early as 2 or 3 weeks of age, that's an indication that there's a bit of trauma. And the work of Anna Verval, who has the wonderful website From Womb to World, she talks about how a lot of babies nowadays, because she does birth photography as well, are born in a startled posture. So between the mommy trauma and the baby trauma, we definitely need to look at ways to change our approach to childbirth. But childbirth is a physiological process that is very complex. It involves a complex cascade of hormones and neurotransmitters, and it involves psychology and emotion. And so, Ina May Gaskin, a midwife who I greatly respect, who's written many books on the subject, she talks about things like sphincter law and being nice to women in labor, and simple things like that, like being nice to someone in labor. Medicine doesn't have anything to do with nice. And I've actually seen doctors standing at the foot of women between their legs with their vaginas exposed, yelling and screaming at them, berating them, saying horrible things to them, and finally just getting exasperated with them and walking out of the room in disgust. That was an interesting Freudian slip. Walking out of the room in disgust, and because it was almost a tactic, like, if I'm just disgusted with them, they'll just grow up and start to have the baby. And so there's this emotional manipulation that I've sometimes seen, if not downright abuse, and we can certainly talk about the abuse if you like, but that exists in modern obstetrics to this day in the modern world in New York City and everywhere else, unfortunately. So I think that general childbirth, it can be found, but it's not a given, especially depending on where you live. So in terms of biointelligent childbirth, epigenetics is something to consider. 80% of our genes can be switched on and off through how we live our lives, how we eat, how we think, how we influence our bodies. And so on a genetic level, these things can happen, but there's a lot more going on to it. In childbirth, there's the microbiome, for example, which is not just the gut flora and the, good guys and the bad guys also that live in our gut, but there's a microbiome in the placenta we now know. So there are microorganisms in there that are actually beneficial and that influence the baby's immune system and development. So if a woman, for example, is given antibiotics during labor, which could be done if they're concerned about an infection, group B strep or chorioamnionitis, that can actually cause a higher level of potential autism in male babies, they're now finding, and the other consequences of this are still not known. But that's one example. And then with the microbiome also, after the baby is born, when there's a vaginal birth, the baby takes on the flora of the mother's vagina, ingests it into their bodies, and are exposed to it, and it seeds the baby's immune system, as does the mother's skin, the mother's armpit, if the baby's breastfeeding, near the armpit. Everything that the baby contacts from the moment of birth is also influencing. So the microbiome in all areas is very important. And then there's the physiological cascade of childbirth. So when a woman goes into labor, it's influenced by many things, including the baby's adrenal gland. And this is very, very important. The baby's adrenal gland is as heavy as an adult adrenal gland. And then it shrinks and, becomes more, tied to the baby's size after birth. But that adrenal gland, it's a survival organ, and it signals in part when labor occurs. So the baby knows when the baby is ready and participates with the mother in timing the delivery. When the baby is induced, something very different is going on. It's overwhelming the baby's natural signals as well as the mother's natural signals. And it's not to say that there aren't medical reasons that this should be done, but we're getting to the point where inductions are being done in a much more cavalier manner. And in fact, this year, American College of OBGYN came out with more guidelines saying, hey, stop doing these inductions before 39 weeks, guys. You're having too many babies going into the neonatal ICU. You're having too many unnecessary cesarean sections because people aren't ready. Like, there's actually somewhat of a backlash now within the profession itself saying, come on, this is getting crazy, like 35, 40%. How high does the C-section rate really have to go? Yeah. Like Ina May Gaskin says things like, your body is not a lemon. And it's true. People often don't have faith in their body, and then it's really hard to go anywhere from there. So physiological childbirth means honoring that cascade of neurotransmitters and hormones that the baby and the mother have to guide them through childbirth, and enhance it or intervene if necessary. But don't just do it because you can. Don't just do it because you're afraid of a lawsuit or you want to get home to bed or, because that's the obstetrical climate. I just think that's doing such a disservice to women, and I never felt like I could be that way. I felt like I had to be there for the woman in my care, and I still feel that way, the way that I would want someone to be there for me. And so supporting that physiological unfolding, being kind to someone, spending the time, helping the body unfold, helping people walk around and be mobile in early labor so that the contractions can kick in, or being okay with resting at 5 centimeters if that's what needs to happen for a while. And, in a hospital situation, often it's like, you're 5 centimeters. What are we waiting around for? Let's induce you. Let's throw some Pitocin in. But then there's this consequence, you see. The Pitocin causes contractions that are much less physiologic. They come closer together. They're more frequent. It puts the baby under more stress, and it may make the mother unable to cope with the sensations of labor any longer. So then it might be time like, I need an epidural. I don't feel well. There's too much pain now. The epidural comes on. In my experience, very few of the true risks of the epidural are told to women, such as, your baby could have distress, you have a much higher chance of having a cesarean section, you might not really feel anything, you might have a terrible headache afterwards, you might have trouble pushing your baby out. I feel like very little of this is said. And so the woman gets an epidural, hoping for pain relief. Happens, works out about 78% of the time that it actually helps, which is not as what people's expectation usually is. Mm-hmm. And what happens then is the problem. The epidural causes the psoas muscles to become flaccid. Now let's talk for a moment about psoas muscles. They are the muscles of fight or flight, but they're also emotionally sensitive muscles. So a lot of the stress that we take on in our lives kind of tenses up those muscles, and they're the muscles that the baby is literally leaning against in the woman's body. So when a woman is, let's say, inhibited in labor, the psoas muscles may tense up, and that may inhibit the spiraling of the baby down the birth canal, as well as cause her sphincters to clamp down. But when a woman gets an epidural, the psoas muscles are rendered flaccid and non-participatory. And that can actually, sometimes open things up for people, but it can also just make things stop and almost require an induced labor or Pitocin or a vacuum delivery or a cesarean section even. And so there's a lot that I feel like people don't put together in their minds when they're thinking about childbirth and the physiology of it, and how small interventions, or seemingly small, can contribute to this slippery slope and cascade of interventions that just leads to things like cesarean sections, because, once things start going haywire enough, that's all you really have left to do, to be honest. And what I say in The Business of Being Born, I'm quoting a man who trained me in medical school. In fact, he's the one who was between the woman's legs yelling, as I come to think of it. He was very much a Dr. House type in the obstetrical field. Sort of brilliant, but always asking for pain meds prescriptions. And he said, hey, if in doubt, you just do a cesarean. If you're in doubt, just section them. And unfortunately, that's what's happened in obstetrics since the 90s when I was trained is, this is what really started to happen. They started to use a drug called Cytotec. Cytotec is actually an ulcer medication. It's super cheap. You can get a pill for 10 cents and put it in someone's vagina, and all of a sudden the uterus will kind of start cramping down and the baby will come out, and it's like magic unless the uterus ruptures, and then it's like a hemorrhage emergency and everyone could die. And it was Ina May Gaskin who at first had pointed that out to me, and that it was at the same time in the 90s that they were doing single-layer closures in cesarean sections. So in sewing up a uterus, 1 layer of sutures versus 2 layers, you could see how that might make a little bit of a difference in how it would heal. So think about this. Here we are in the era of vaginal birth after cesarean is becoming in vogue, if not mandatory. You have a surgical protocol that's now saying, you can just do a single-layer closure and get out of there really quick in 19 minutes instead of 21. And literally they were saying that. And then the people who were having the VBACs were being exposed to induction agents like prostaglandins and Pitocin, which have the chance of rupturing the uterus even more. And so what was happening is VBAC became dangerous, but it wasn't dangerous because VBAC is dangerous. It became dangerous because people weren't handling it well. They weren't using medications that were safe. They were using dangerous induction agents with patients who had uterine scars that did not have good integrity. And, yeah, there were some bad cases. In fact, I had a bad case back in 1998, and, you never forget things like that. So, yeah, knowing the history and how things have developed in the last 20 years is very illuminating.
Wow. I'm like, I have nothing to say to that. It's crazy. I've been reading Ina May Gaskin's books, and I've read about the sphincter a lot, and I would like to talk a little bit more about that. But one thing I wanted to add, when you were mentioning about the induction, the Pitocin causing these uterine contractions that are so much stronger that even a woman who wasn't wanting pain medication now really requires it because it's so intense, and then she's not able to be weight-bearing and utilize gravity and squatting to help this baby move down the canal. She's bedridden, and, structurally, you mentioned the psoas and the pelvis, the alignment, things are much harder to birth when you're laying on your back.
Right. I always say, could you really literally poop laying on your back? I mean, just because you have sex laying on your back doesn't mean you need to give birth laying on your back because it comes out of the same plate. No, it makes no sense. In fact, there is a 1 centimeter additional diameter of the pelvis when you're upright as opposed to lying on your back, flattening it all out. So it actually makes no sense. The position is called dorsal lithotomy, and it was developed by one of the King Louis of England so that he could watch his mistresses giving birth from behind a curtain because he thought it was kind of titillating. So that's how this position was developed.
Oh, my gosh. That's crazy. I've never heard that either.
Oh, yeah.
Oh, gosh. What is going on? Let's talk a little bit more about sphincter law, because when I was reading that in Ina May Gaskin's book, I was like, that makes so much sense to me. The cervix is like a sphincter, and when you're feeling fear or you're feeling, emotions that are negative, sphincters close up, and that is, the last thing you want to happen when you're birthing. So can you talk a little bit more about that?
Yeah. So let's imagine an animal giving birth in nature. They would usually try to find a little nest or a bush or someplace safe to hang out, and then they would start the birth process. But then let's say they heard some rustling in some trees nearby, and they were a little bit on alert and concerned that a predator might be coming. Well, it wouldn't be in that animal's interest to continue the birth process if there's a predator, because then mommy and baby are both going to get eaten. So in nature, the way sphincter law works is if there's fear, it shuts down the birth so that the animal can then move to a place of safety, and then things can switch back on again. In modern life, our stress is very different. It's not usually about running away from predators. It's usually about like work or money or relationships, and relationships with like people in society, and nurses who are mean at the hospital, and doctors who are saying, no, you can't eat or drink, or whatever the case may be. Or it may be that the woman was sexually abused as a child, or it may be that her partner is annoying her, or there's so many potential issues, but any one of those things could just shut things down and make it so that the body doesn't want to give birth. And the idea of the mind-body connection is so important here, because the intellectual mind can say, of course I want to give birth, but if the body has other ideas, it's just not going to happen. So it really does mean that the mind and the body need to be synced up, but also that the environment is supportive. So if a woman is fearful that she's at home, she should probably go to the hospital. But if she's terrified in the hospital, either people have to help her feel comfortable, or it's maybe not the best place for her. And a lot of people don't think in those terms. There's this sense in medicine that overwhelming and overriding the body is just what we do. And yes, sometimes it is, but it's not what we have to do by default. And certainly in childbirth, it can cause a lot of detriment and risk.
Right. She was even telling us, Ina May was telling a story in her book of a woman whose cervix had started to dilate and then kind of had stalled, and she would have her just loosen her mouth and her lips and just laugh or kiss her partner, or just anything about opening the mouth actually opens the cervix, which I thought was also really fascinating and, important for women to hear.
Well, yeah, and it does make a lot of sense. And, I think one of the things is like fluttering your lips. She goes,
right.
It's a way of releasing down there. But it really does, it helps with peeing, it helps with pooping, it helps with childbirth. It's kind of like, again, so it's like a form of we could call it childbirth yoga. It really is. It's a way of connecting the mind to the body, first of all, but also a way of using what I call the special little toggle switches and secret buttons in the body to get the unconscious body that, the conscious mind just can't tell it what to do, to get it to do more what you want. You have to know, what is the body like? The body likes love and connection and, stuff like that. So, yeah, supporting a woman that way, but also having her work with her mouth. I mean, just think about it. The gut tube, it's this tubular thing, and the cervix, it's a tube. So working with the mouth as if it were tubular can influence the cervix.
Mm-hmm. Yeah, that was a cool tip, I thought. So if you could share with our listeners about some of the best tools to help prepare for a gentle birth, what would you say?
Well, first of all, I would say that the right mental attitude going in, and this isn't to make you feel like if you're going in scared that that's anything wrong. It's more that having a somewhat faith that your body is not a lemon, as Ina May says, and that you can do it is important, and then preparing your body in that regard. And what preparing means is learning what you can about how childbirth works, because knowing what's happening in your body makes it a lot easier to actually go through and participate in the experience, considering also that there's a lot of mythology in our culture and things that people may say that can really throw you off. Squatting. I really like squatting, and I know it's not for everyone. There may be instances where it's not advisable, but in general, squatting is something that we don't do a lot of in our culture. We tend to sit in chairs, and that really does a number on our hips, our pelvic floors, our low backs, and that can make it harder with childbirth because our pelvic floors aren't necessarily in as good shape. And what squatting does is it gives us the opportunity to have the entire pelvic floor, that whole bowl, kind of go onto a stretch. I think that the reason why some people don't advise squatting in pregnancy is that they're afraid that it'll prolapse things or things will be too loose. It's something not to start when you're necessarily 8 or 9 months, although gingerly and carefully one could, if you're not in the habit of it, by holding onto a piece of furniture or opening a door and holding both sides of the doorknob, possibly with a little door stop in the door so it's not moving around. But I think squatting is very, very important. Definitely from also the perspective of squatting throughout pregnancy if possible, because the idea of the center of gravity, a lot of people designate the center of gravity as S2 or the second sacral vertebra, and there's this myth kind of that the center of gravity changes during pregnancy, and it kind of isn't that it changes, it's that the body developmentally during the pregnancy can be more or less balanced in relation to these changes, and squatting helps with that balance because essentially squatting helps you build a butt to balance that belly, and it's important to have a nice strong butt actually, and not by like squeezing it or doing anything, but using it physiologically in squatting. So I think that both the mental preparation as well as the physical preparation with squatting, probably a good natural childbirth-oriented class, so you learn about the physiologic techniques. And it's not to say you shouldn't know about epidurals and C-sections. Everyone should have information, but definitely a class that makes you feel empowered and that you can really do it, because the truth is, why think otherwise unless there's truly a reason why not? I mean, really, we were designed for this, and it's true that in the modern world, we aren't living close to nature, and our bodies do pay for that and suffer, and that does play out somewhat in childbirth. But there's no time like the present to really, start moving and, go to a good prenatal yoga class, for example. I really love the Ma yoga technique taught by Mia Borgata in New York City. But there are other great prenatal yoga methods. Beyond that, though, there's also good nutrition. So important to have good nutrition, and that's a whole topic in and of itself. But just to summarize, healthy fats from healthy sources are very important. They contain a lot of fat-soluble vitamins, healthy proteins, and, moderate amounts of carbohydrates, and certainly a whole foods diet that's as naturally and whole food sourced as possible to avoid a lot of the toxicity that's now in our environment, because we know that affects the baby, but it also affects the mommy and her tissues in terms of preparation for birth. And, for example, a super high-carb diet isn't the best because in pregnancy it won't be handled as well, and it can just make a real big baby that could be harder to push out, for example.
Okay. Did you have any other thoughts that you wanted to share regarding preparing for gentle birth?
Yeah, I kind of stopped because I didn't necessarily want to go on and on and on. But, yeah, for sure.
One thing that came to me was the provider. If you could maybe speak a little bit more to helping women choose a birth provider.
Yeah. So in terms of choosing a birth provider, I realize that I'm in New York City where supposedly we have all the options in the world, and to be honest, even here it's not so simple. So there are different settings for birth, and there are different providers. The settings would be home, hospital, and birth center. I'm sure that there might be others that I'm not thinking of, but those seem to be the three basics, unless somebody goes to the ocean or does something cool like that. And then there's, people do. And then there's doctors, there are midwives, and there's something called free birth, which I don't have much experience with because I'm a doctor, but free birth means people do not have a birth provider. And to me, that's a very personal decision that I'm not really going to speak about. But in terms of doctor versus midwife, I think that's a very important question, and it's an evolving question nowadays because there's almost like these culture wars, I don't know what else to call it, between doctors and midwives, and it's very unfortunate, to be honest, because right now we've got on the one hand women who clearly value and desire natural childbirth at home, and I'm told that even the word natural childbirth is meaningless now. We can talk about that, but natural childbirth meaning no drugs, what it meant when my mother had me in 1965, no drugs, no epidurals, no interventions like that. But doctors are often not in a position to offer women a natural childbirth experience or a physiological birth experience for the following reasons. Because, A, they work in a hospital environment that's highly litigious in many instances. And in an environment like that, the doctor often needs to be very much more concerned about preserving their own integrity, meaning not getting sued. They don't want the hospital to get sued. There are certain things that can happen that are more likely to create a lawsuit, and they know it. And those things are vaginal birth after cesarean, and what I was saying before, allowing birth to progress towards a vaginal delivery without doing a C-section at an earlier time. And it's kind of this gray area sometimes when that has to happen, and certainly I've seen that in different cities, or city versus suburb versus, it can be very different the way that these things play out. And so looking at different hospitals, even within the same city, you'll find different things. So, all right, so you got doctors. Usually they practice in hospitals. Sometimes they might practice in birth centers. They may or may not be willing to support physiologic childbirth. It's definitely something to discuss with them. If it's not something that they're typically accustomed to doing, my feeling is that they may give lip service to, but not necessarily be willing to follow it through. So it is important to be really sure about what you're being told and make sure that the doctor's colleagues, for example, are on board with this, because if the doctor is in a group of 4 or 6 and the other 3 or 5 are not on board with this plan to deliver your breech baby vaginally, for example, then you're going to be really disappointed. Or, for example, if you're promised the birth center, but when you go into labor, the doctor calls and the hospital says, oh, we don't have any nurses available. Like that's, I would fight the hospital against that, but if your doctor won't, then that's something that you should know. So it really is, I think, in this day and age, doctors who are willing to go above and beyond for their patients who are on physiological childbirth, because the profession itself almost looks down upon it, and it's very strange to me why that might be. So a lot of people stay home for this reason. I think that a lot of people would be highly willing and fine with having childbirth in a hospital if they felt that they could get the kind of compassionate and physiological care that is only being given lip service at best by most doctors. And it's unfortunate that, because I've spoken on panels with chairmen of OBGYN, and it's almost like they don't see what's going on. It's as if they think, oh yeah, we are giving women that experience. You're not giving women that experience. You're hooking them up to fetal monitors. If you're having anesthesiologists interview them for 30 minutes about all of the things that might play into the epidural that they already decided that they didn't want, but now you're trying to talk them into, if you're not, quote, allowing her to get up and walk around when contractions are happening, all of these things are a problem. So, I'll give you some examples. So I, as a doctor, how would I get around some of these protocols that supposedly exist at hospitals? Like, all right, you can't walk around because you have Pitocin and we need you to be hooked up to the fetal monitor at all times while you have Pitocin on. Well, that's very restricting. So I would find ways to get the woman up to the chair or, walking in a short distance, or take her off the monitor to go to the bathroom for 5 minutes at a time. I mean, there are small things that you can do. Or let's say the hospital protocols that you can't eat or drink, which a lot of people think are ridiculous, but not everybody. And speaking with the anesthesiologist about, well, is it okay if she has something to eat or drink? If there's a cesarean later, would that be okay? There are ways to get around some of these things. Walking around in labor, usually once the water is broken, it's said that women can't because, well, what if the cord prolapses? What if the umbilical cord literally comes out before the baby and the baby's head crushes it, right? Well, what if the baby's head is well engaged against the cervix? It's sort of impossible for the cord to come out. So it's not that risky to get up and walk around. I think that individualizing care is what I'm talking about, and I think that there are standards of care and a lot of liability, and that makes it very hard for doctors to feel that they can truly individualize care. And so on some level, I understand where my colleagues are coming from, and I, in a way, can't blame them, but I also feel like they're doing a disservice in that, I don't know, I think maybe because I would really feel terrible if I was treated that way, that I could never conscionably do that to somebody. I mean, I couldn't. When it got to the point in my career where I was just getting so annoyed and even thinking, it would be just so much easier to do a C-section, I realized, maybe it's time to sort of transition into a different phase of your career and do more, because I realized that burnt out after 10 years, because not only was I being an obstetrician, I was kind of putting my own body as the buffer zone between all of these hospital protocols, which weren't always for the mommy and baby, best case scenario, but more for prevention of liability. That just seemed wrong to me after a while. And anyway, so whether a doctor is willing, able, or, in a position to help with physiological childbirth is definitely something to explore. And then, midwives. I want to talk about midwives because, on the one hand, midwives are perceived as lesser than doctors because they don't have the surgical skills that doctors have. But I would argue that that is not the case. Doctors don't always have the skills to help a woman with physiological childbirth, and in fact may never have even seen a physiologic childbirth in their entire career. So midwives do have a very, very important place, and we have to remember that midwives are the primary birth providers in human culture for all of time until fairly recently. Only in the last several hundred years have midwives as a profession been sort of denigrated, and we have to remember witch burning, okay? I mean, really, are we still thinking in these terms just in a more modern sense, let's say? Because the original witches, they were independent women, they were midwives, they were herbalists, they were strong women in their communities who people respected, and men who wanted to gain other sorts of power had to burn them at the stake, had to make up crazy stories about how if they sank and drowned, they were actually saved and they weren't really witches, and if they floated out, we have to stone them to death. So there's a lot of history there that's been buried. I mean, if you think about it, a lot of women's rituals have been subsumed into the culture as sort of like these folksy, what they call old wives' tales. Think about even palm reading. I mean, even saying it almost makes you think nobody will get this. But honestly, the way you hold your hand, the crease of your palm, how you neurologically have the architecture of your hand says a lot about who you are and how that hand is connected to the rest of your body, the same way as if you scoop a cup out of the ocean, you know pretty much what's going on in the ocean overall. And so the idea that you could read the body from one of the parts is lost to people. I mean, it's something that it just sounds so odd even when you first hear it, but the body is really structured that way. So midwives, I think of midwives can work in hospitals. They can be very, very medical. But traditional midwifery and what a lot of midwives are offering today is the more physiological birth experience, the birth experience that honors the woman's physiology and the baby, that doesn't seek to impose interventions, but seeks to find ways to support and empower the birth process. And so, of course, interviewing a midwife, you have to also think, what is their backup plan? What is their training? There are many paths of training for midwifery, from direct entry midwifery to nurse midwifery. There are lay midwives who don't have a formal degree necessarily, to nurse midwives who have a nursing degree. So there are all kinds of variations. And in some states, there are midwives who are practicing in ways that are considered not necessarily that safe, and so it is important to really understand the reputation of one's midwife in the community as well, because it's the midwives who, maybe few and far between, are practicing in less safe ways, who sometimes that's magnified by obstetricians to try to give midwifery a bad name. And I personally know a lot of midwives. I've attended births with midwives, particularly Robin Lim in Bali, Indonesia, where there isn't a lot of great medical support, to be honest. And I think that midwives do a great job with physiological birth. They have a lot of patience with mothers. They know how to draw out that beautiful physiological unfolding. And to even say it that way, it's like, that's not medical. Why would that be important? It's really important. It's really important because the neurology of this sensitive baby is passing through the mother's birth canal and is going to be welcomed into our world, and how that happens makes a huge difference for that baby developmentally, and it also makes a huge difference for that mother and how she's going to feel confident in her own mothering skills for the rest of her life. Birth can be an empowering, joyful experience. It can be an orgasmic, ecstatic experience, and it can also be a very devastating and traumatic experience. So your caregiver and who you choose, whether it's a doctor or midwife, it's more about the person than the provider, is probably the last thing I'll end in saying. That's really what's most important. You have to find the person who will give you support, who will be there for you, and who will help you achieve the most physiological birth if that's what you want, and apply interventions judiciously and appropriately, but only when truly necessary.
Wow, that was beautiful. I mean, that really just sums it all up. It's really, who is this person? Is this the type of person that you can trust, that they are on your side to help support you in achieving that birth of your dreams?
Yeah. And that can be done with complete safety and the whole medical aspect taken care of. And that's what I think people don't always understand. Even doctors seem to not think that it's possible.
Right. Right. It's possible to safely have a natural birth.
Yeah. I mean, wouldn't it be cool if you were in a room and it was like, all beautiful and natural and everything, but then right on the other side of that room, there's a room that you could have a C-section in. And it's interesting. There's a hospital that I volunteered at before I went to medical school in Philadelphia. It's now closed. It was called Booth Maternity Hospital. And it was essentially a midwifery-run birthing hospital with 2 C-section rooms. That the midwives are pretty much running the place, and then they had section rooms if necessary, and it was an interesting place. I loved it. And when they closed, their midwives came over to the hospital where my residency was, and so even though I had volunteered there previously, I then got the benefit of the doctor and midwives from that maternity hospital coming to where I was doing my residency. And so, it was a very nice environment to be trained in. The midwives were always trying to kick me out of the room because they just thought, it's the resident. She's going to want to do all this mucky stuff to the patient. I'm like, no, I'm here to help, believe it or not.
What a great experience, and I'm sure, it was really mutually beneficial to learn, to watch, what a physiological birth looks like.
Oh, it was wonderful. I think I really lucked out with my training because I had certain proclivities, but I lucked out with my training for sure.
Yeah. I'd love for us to close with sharing your story, your experiences of working with Robin Lim in Bali.
Okay. Well, Robin Lim and I became close friends very quickly when I went to Bali in 1997 for the first time. I pretty much was thinking that what I wanted to do was find something to do internationally. And when I read Robin Lim's writing in Midwifery Today, I realized that she was brilliant, and also I thought that Bali was a really cool place. So that's how I ended up there the first time. But it was truly wonderful. There was no birthing clinic when I first came there. Robin was working out of a loft above her kitchen, essentially on a straw mat. And we would ride around on motor scooters to births and things like that. And, what people didn't really have phones yet. There wasn't a cell phone or internet thing much in Bali. And I don't even think that I had a laptop yet. So it was extremely primitive. We didn't have pagers. It was a very different experience than it is now. So what happened with Robin Lim had been living in Hawaii, and when she was pregnant with her 5th child, she moved to Bali, and the traditional midwives and healers in the area, I think, had actually quite recently passed away. And so she realized that she didn't really like many of the birth options on the island, and she decided to have a free birth at home. So she had her baby at home with her husband in attendance, and she birthed before, and he had previous home births with his ex-wife, who she had actually died. She was one of Robin's good friends. And so when her baby was born at home and everybody knew, they were like, we would like you to do this for us. We like this. And so she started to attend births at the hospital with people. And I think that it was the night of the World Cup, and all the OBs wanted to watch the soccer match. They were like, why don't you go deliver the babies? And so she really gained a lot of skills quite quickly in that setting. And, of course, at some point she started to do home births. And when I got there, she was in the process of completing her North American Registry of Midwives certification, so I helped her with advanced obstetrical skills like suturing of 4th-degree tears. There's nobody in Southeast Asia better than Robin Lim and those others who we have trained at suturing 4th-degree tears or any other kind of obstetrical laceration, I will say. External cephalic versions. I just taught her how to turn breech babies to head first safely using handheld Doppler to check the heart tones throughout, things like that. So it was a really wonderful, mutually supportive experience in which she taught me more about the hands-off patience approach, and I taught her a lot of obstetrical skills. And, between the two of us, I think we made a great team, and I think our dream in life would be to be together all the time in one place doing our work together. But I'm in New York, she's in Bali. We get together when we can. I love nothing better than to go over there and teach suturing to midwifery students and, do yoga retreats for women and things like that. And so stay tuned for more of that in the future. But now at this point, she's got Yayasan Bhumi Sahat. She has a clinic. I believe that they're building a new clinic now since she had won the CNN Hero Award in 2011, but she was certainly well honored and deserved to win that because she also has a clinic that is developed in Sumatra, which was after the tsunami there over a decade ago. And she's also done work in the Philippines where she has a lot of family, as well as starting some of the birth projects in Haiti that are continuing under different names to this day. So Robin Lim is, she really is a hero, not just to CNN, but to me and to lots and lots and lots of mommies and babies. And, her work in Bali is wonderful. And there's actually some footage that was shot about 3 years ago between me and her having these conversations, and I think we're going to be making a film out of that, so stay tuned. But it's a lot about, love and childbirth and how important it is to welcome babies into the world in an environment of love. And I think that it's so true because oxytocin, the hormone of love and attachment, it surges at the time of birth. Only when there aren't drugs or epidurals, though. And that's what's interesting. It's like if there are drugs and epidurals, it actually takes that away and interferes with attachment and bonding between the mother and the baby to the point where primates who are not humans, like any monkey, you give them an epidural, you induce their labor, you do a C-section on a non-human primate, they're like, who is this? They're not related to me. I'm not taking care of it. Go away. And that's sort of frightening. The fact that we as humans can intellectually override that and love our children is great, but to think that the physiological underlying biological connection is being somewhat dampened, if not eliminated, is a disturbing fact to know of. And what's also interesting is that there's this diminishment of chloride ions in the baby when that oxytocin rush happens. And apparently sometimes there are issues with autism. And some people are now talking about how they believe that epidurals and inductions and non-physiological birth techniques can be contributing to autism by interfering with that oxytocin and love bonding and attachment connection between mother and baby, which we know is so important. For decades, they had the horrible Harlow studies with the rhesus monkeys and the children in the Romanian orphanages who are deprived of love and attachment, and they really do become very, very screwed up. I mean, it's not good. They become highly traumatized. And so, even to expose our children to small things that would cause trauma, why would we want to do that? We have enough small traumas in this world that cumulatively make us nuts when we're adults. So I think that Robin Lim's mission is to really bring babies into the world in an environment of love and compassion, and it's a way to really change the planet. She calls it guerrilla midwifery, sort of like, instead of like, guns in the bushes, it's like midwifery in the bushes. And, it really, hopefully that will be healing for people and the planet.
Wow. I mean, it's so true. I think she also says gentle birth equals a gentle earth. I mean, the way we're born into the world will, stay in our nervous system, good or bad. So for more peace, we need more peaceful, gentle birth.
I think so. I think that if you enter the world in an environment of fear and possible retribution and liability, and that's what's on everyone's minds, it's not good.
Yeah.
Have you ever gotten in an elevator with people and you're like, ooh, somebody in this elevator is like really kind of depressed? Like you can feel these things. HeartMath says that, we can feel up to 15 feet, what's going on. So there's this biological field that communicates what's unspoken, and certainly holding a baby in your arms, they're perceiving. Certainly when the baby's in the body, they're getting a lot of physiological signals from the mother throughout pregnancy, but certainly during labor. And to think that, all of these nuances of information have no importance is very short-sighted. All of the nuances do have importance, and, let's do our best, really. Some other physiological childbirth techniques that I think are important that Robin in specific talks about, for example, in her book, Placenta, the Forgotten Chakra, the book that I helped her out with because I'm really, I own a yoga studio, but she talks about delayed cord cutting and lotus birth, and it's funny because it's only after the book came out that there was some medical literature about these issues. But here's the story with delayed cord cutting. It used to be said that if the cord was not cut immediately, this would risk the baby becoming jaundiced, when the skin and the eyes turn yellow from excessive blood cells that haven't been broken down, and that this was a bad thing, and therefore the cord should be cut immediately. And, of course, this allows the baby to then be handed off to various pediatricians or nurses to be, quote, resuscitated, even if they don't require resuscitation formally. But what's going on here? So now there is something else to mention, which is that a lot of people are doing cord blood banking or donating cord blood, and there are issues with that because the impression is that cutting the cord early allows that high-pressure system to just pour some blood into those test tubes to go to the lab or to the cord blood bank. And that is true, but then the baby doesn't get it. So thinking that you're going to bank the baby's blood that the baby needs now for some future possibility that isn't even you don't know what's going to happen if they'll ever need it, right? Or that you're donating it to someone else's baby who may or may not ever need it. See, the baby does need it is what they found. And what they found is that when the cord is cut immediately as opposed to delayed until, let's say, it stops pulsing or at least a minute or two, the baby has a much higher chance of having neonatal anemia. And neonatal anemia is an iron deficiency that can actually cause brain damage and developmental delays in the baby's brain development. And so it's actually depriving the baby's brain of necessary nutrients to cut the cord early. The other problem with cutting the cord early, though, comes through the connective tissue perspective, and this is highly significant for the trauma physiology. When the cord is cut, the cord is connective tissue. It's connective tissue filled with this substance called Wharton's jelly, and it's got the baby's blood vessels in it. So the blood vessels are still on high pressure when the placenta is still pumping to the baby. So when the cord is cut, there's a retraction. I mean, you could kind of imagine that if you cut something that's on tension, it'll snap back. So when the cord snaps back, it snaps back through the ligament into the liver. There's a falciform ligament, the ligamentum teres, the coronal ligament. There are different ligaments that attach the liver to the body, and the ones that attach along the anterior abdominal wall and to the umbilical cord that bring the nutrition up. First of all, that nutrition will immediately stop, which can be a little bit of a shock to the baby, certainly, but the other thing that happens is that those ligaments retract very rapidly up into the baby's diaphragm, which is, the muscle of respiration, which just, the baby is just being born, and here you are cutting the cord while the baby's trying to coordinate breathing for the very first time, and all of a sudden the liver and its ligaments are snapping up into the diaphragm of the baby's chest. That can be a trauma to the baby on a physiological level. Sort of like, you stick a bulb syringe in the baby's throat, you kind of gag it. Maybe you need to take the secretions out, maybe you don't. These are things that people should really be thinking about. And so now that we know that delayed cord cutting is actually physiologic, I really think that there's no reason that anybody in obstetrics today should not be doing this, because even resuscitation of the baby can be done right there while the cord is still attached, while the placenta is still inside. It can be done. I've done it many times. It's just a matter of willingness of the team. If it's the people who are like, oh, that's weird, so I won't do it, who are making problems. It's like, all right, so bring your equipment over to the bed, bring it to where the mother is, and do it right here. There's no reason that you can't. And so what they're doing more, even in cesarean sections, is after the baby is brought out of the belly, they're doing more resuscitation on the abdomen of the mother, even bringing the curtain down so that she can see and contact her baby. And there's a whole different protocol that's being implemented in certain institutions right now. And so I know that it can be done, and I'm really hopeful that a lot more institutions will start to implement these more gentle and empowering protocols. Even a C-section can be made more humane and honor some of these physiological principles.
I've read that book, and it's fascinating, even just stories of reviving a baby by putting the placenta while it's connected to the baby in a bowl of warm water and massaging it, and it really can still bring life to that baby even once it's, out of the mother's body.
Yeah. I don't know if she talks about it there, but yeah, there's a long tradition of dogs licking the placenta of the baby that seemed to have died, or the puppy that seemed to have died, and the puppy kind of reviving. And so yeah, there's definitely a precedent for that. And I think the other thing she talks about is the life-saving properties of placenta, that when you inject a mother with Pitocin, when you give it to her through the IV, when you've given her Methergin, when you've done uterine massage, when you've done nitroglycerin, when you've done all these things to try to save her life from hemorrhage, and it just doesn't work. And then you put some placenta in her mouth and have her chew it up and swallow it, and the bleeding stops, and you realize that's some powerful stuff there. And to be honest, in nature, I don't know if you know this, but all mammals eat their placentas. Yeah. All of them. Goats, all the vegetarian animals do. I was born and raised vegetarian, so I actually have a friend who has a goat farm in Pennsylvania, and so I was thinking, well, it would be compassionate to eat a placenta, and I don't know if I should eat other humans' placentas, but maybe I could eat one from a goat. And my friend was like, they need it. They eat it, Eden. What are you talking about? I was just like, oh, yeah, of course. And so it's interesting. I mean, I'm not sure why humans, got out of the habit, or if we have, if primates just don't do it. But the fact of the matter is it is life-saving. And when the drugs don't work and something that's right there, right in front of you does, that says a lot. That's very, very powerful.
Well, I am just so grateful that you were able to come on the show today and share your wisdom and knowledge with our audience.
Thank you. I am so honored, and thank you for your kind words.